Hi, welcome back to my channel. So in this video we will be talking about biomarkers of aging that we can use in research to improve outcomes of older adults with cancer. So I will talk a little bit about what makes a good biomarker of aging, and then we will look at the most promising biomarkers that are currently out there. So let's get started. So in my previous videos I showed that the outcome of older adults with cancer is generally much poorer than in younger patients. And this has several reasons. But one of the reasons is that we are not really using individualized treatment strategies that are evidence-based at the moment because they simply do not exist. And ways to improve these outcomes could be to develop more prediction models, to use geriatric assessment as a form of individualization of treatment, so looking at clinical characteristics of aging, and this can be measured in a geriatric assessment, but also biomarkers of aging could play a role here. So first let's take a look at the current options that we have to predict outcome of older adults with cancer. So the largest amount of evidence that is currently available applies to clinical markers of aging. And these include geriatric domains that we can measure by a geriatric assessment and also sarcopenia. And in addition, if we look at the tumor characteristics, we can simply look at the size of the tumor, the localization, the extension and the possible lymph node, things like that. If we then look at biomarkers that are currently available, there's especially a large amount of evidence for cancer-related biomarkers, which could be tumor-related, but also blood biomarkers. And the gut microbiome receives a lot of attention in research. But so far, the combination of biomarkers of cancer and biomarkers of aging has not been studied in very much detail. And if we then look at the biomarkers of aging that are currently available, the most commonly studied and the most commonly known markers that we have are senescence markers and immunological markers. And these will be the topic of this video. If we could find a way that we could really combine all these factors together, I think this is the holy grail to really improving treatment outcome in older adults. And this will really make a difference in the future. So first let's take a look at what makes a good biomarker of aging. So the American Federation for Aging Research states that a good biomarker of aging should predict the rate of aging, obviously, but it should also do better so than just using chronological age, because otherwise it would not add much, obviously. Then it should monitor a basic process that underlies the aging process, and it should not include the effects of the disease that we want to study. And this is immediately an important limitation of using biomarkers of aging in cancer research, because many of these biomarkers have an underlying etiology and that also influences cancer occurrence. So I will get back to this, but this is already an important pitfall of this type of biomarkers. Then it should be a biomarker that should be able to be tested repeatedly without harming the person. And finally, it should be something that works in humans and laboratory animals. So first of all, let's look at some senescence markers. And probably the most well-known is telomere length. So telomeres are basically the end of the chromosomes that become shorter with each replication of DNA in our chromosomes. And this means that when we age and when the DNA has replicated many times, telomeres can become shorter, and this is a marker of senescence. And this recent meta-analysis included 25 studies, and in which over 120,000 subjects were included, with patients with many different diseases and also healthy older adults. And it showed that a shorter telomere length was associated with an increased risk of all-cause mortality. However, there were some limitations to the current studies that are out there. For example, there was a large heterogeneity between studies and populations. So there were many different types of populations with different diseases, for example. There was a smaller effect observed of this association in the oldest patients. And importantly, the techniques of how we measure telomere length are quite difficult and are difficult to apply in daily clinical practice, which is an important limitation if we really want to use this to improve outcomes of our patients. And finally, but also importantly, shorter telomeres have been associated with the occurrence of cancer. And this means that this biomarker does not really fulfill the criteria for a good biomarker of aging when we look at cancer research specifically. Another marker of senescence is the p16 gene, and this is a cell cycle inhibitor and a tumor suppressor cyclin-dependent kinase inhibitor that has been shown to be linked to cellular senescence. In that case, it's upregulated. Studies have shown that it has been associated with measures of clinical frailty, such as cognitive decline, but also functional decline. However, again, it is a gene that is quite difficult to measure, and general laboratories of small rural hospitals, for example, cannot do this. And again, it is a gene that has been linked to both cancer occurrence and outcome. So still, it does not meet the criteria for good biomarker of aging in cancer research, unfortunately. So markers that are possibly more easy to measure and are more widely available in many laboratories are inflammatory markers. And we know that in older adults, especially if they are also frail or have measures of frailty, there's more frequently a low-grade inflammation observed that may even exist for many years. And this is called inflammaging. It's characterized by increased concentrations of pro-inflammatory cytokines, and these can include CRP, TNF-alpha, IL-6, but many more. But again, there is a strong interaction with the disease, because we know when cancer becomes very active, these inflammatory markers can also increase, and for example, albumin can decrease as a result of the cancer itself. So these factors may give some estimation of frailty in an older adult, but they are not very specific, and they can also be disease-related. So again, they are not ideal to use in cancer research, although the measurements are more easy than the previous markers I discussed. And this systematic review showed that especially IL-6 and CRP are strongly related to frailty in different populations. But again, this is not specifically in patients with cancer, so this is a quite heterogeneous review. But still, it shows that it might be an option to look at this in more detail. If we zoom in a little bit more on the immune system in relation to cancer, I can strongly recommend to read this review, which was recently published in Cancers, because it gives a nice overview of all the changes that occur when we age in our immune system. And I already discussed the inflammaging part, but also in the adaptive immune system, we see that aging is strongly related to changes in our immune system. And importantly, we see that especially T cells tend to decline a lot in their functionality when we age. As an example, the number of naive T cells, so T cells that have not been primed during our life course, decreases with age. And we see also that the suppression of our immune response increases when we age. So this means that we are less capable to achieve a good immune response when patients age, specifically if they age in a more frail way. As an example, this study showed that the T cell but also the B cell populations of patients with poor cognitive function are strongly different from patients with a good cognitive function. And also there have been studies that show that there are changes in these type of T cell populations in patients living in a nursing home compared to patients in the general population. And these changes are especially interesting if we think about the era of checkpoint inhibition where we're currently in. So checkpoint inhibitors are a form of immunotherapy that have strongly improved the outcome of patients with several types of cancer, especially in patients with melanoma, but also in other types of cancer. And interestingly, we see that the checkpoints that are targeted, for example PD-1, are also associated with aging of our immune system. So PD-1 is actually a senescence marker that is more often upregulated in older adults. So this makes it quite a promising treatment, specifically in older patients. And if we look at currently known biomarkers that are predictive for having a response to checkpoint inhibitors, we see that there's a large overlap between markers of immune senescence. So for example, as I previously mentioned, there are less naive T cells available in older adults. CMV status plays an important role here. I will not go into detail here, but it's also a factor that has been associated with a poor immune response. As I mentioned before, the suppression of immune response is often upregulated in older adults, and this is also unfavorable if we look about checkpoint inhibitors. But on the other hand, PD-1 expression is often upregulated in older adults, which may be a factor that makes that patients may benefit even more from checkpoint inhibitors. But so far there have not been many studies that looked really into detail into this and looked at these mechanisms specifically in older patients. So to summarize, biomarkers may improve individualized treatment in older adults, and the most promising biomarkers are probably inflammation and immune senescence, specifically if we look at checkpoint inhibitors. However, unfortunately, at this moment in time, it's too early to implement these biomarkers in daily clinical practice, because laboratory techniques are not widely available and can be quite complicated and also expensive. The outcomes of the studies that have been performed are quite heterogeneous and are not very strong in terms of the quality of the evidence. And there is a very large interaction between the occurrence of frailty and a poor way of aging, so to speak, and the occurrence of cancer. And this makes it difficult to use the biomarkers that we currently know in our cancer clinic and our cancer research. So I really hope that this overview helped you a little bit to gain some insight in biomarkers of aging, and I really look forward to see you next time.